Hi, I'm Anthony Gosh, a consultant spinal neurosurgeon and founder of the Spine MDT. I recently had a conversation with Professor Stuart McGill, who is a well-known back pain specialist in Canada, who's written The Back Mechanic and is quite well known in the online space. And we had a discussion about ways to assess someone with back pain and if you actually really need any special investigations. And we both agreed actually the clinical examination is the most important factor, the history and the examination. And in this video, we're going to discuss how we assess that and how we get this information and when investigations can be helpful.
Let's start with, in patients with lower back pain, but they don't necessarily have pain shooting down the legs, that, the sciatica that we commonly see. How do you assess them and investigate them?
In our world, we get referred people with non-specific low back pain. That doesn't exist in our world. Could you imagine a patient coming in and saying, "Doctor, I have non-specific leg pain. Can you give me an exercise?" Or, you have nothing to guide by. So we give a very thorough assessment to try and make the pain very specific. And that guides us as to what we would suggest the patient not do to wind down the pain sensitivity, and then what they should do to build a general robustness for life that's hopefully pain-free. So if I could give an example for your listenership, here's a typical pattern, and you'll resonate with this. You have a 30-year-old, so there's a clue in that age demographic. Sitting, walking, they give differential effects. Sitting causes their pain, and going for a walk takes their back pain away. Now let's go to their father, who's 65 years old, and they will show exactly the opposite. Walking causes his pain, and sitting down gives relief. So there's two people with the symptom of back pain. It's not non-specific. They both have very different pathways and no doubt very specific avenues to pursue. In my view, neither would require imaging. They fit a little bit of a category, and a few orthopedic tests should reveal what they should and shouldn't do. So when would we be suspicious and suggest that imaging is required? If the pain has been there for quite a long time and the pattern doesn't fit. It doesn't fit what would be typical of discogenic pain, which is what I described in the 30-year-old, and more arthritic stenosis type of pains, which is what I described in the 65-year-old. So that's when we would suggest imaging, and the assessment really informs the radiology assessment. So to give an example there, you might have a puzzling patient. Sitting really doesn't cause their pain, but driving the car does. And when we do a few orthopedic tests and ones that change the stretch on particular nerve roots, we notice that what is peculiar about driving, it's having the head up and extending the right foot to the accelerator pedal. There's something peculiar about pulling the nerve with knee extension, putting the leg in that position that's causing the pain, but when they sit in the chair watching the telly, it doesn't come. So that informs us to look at the nerve roots on the right-hand side of the fourth and fifth roots that serve the foot. And the radiologist may or may not have that information, but we do. So we know what to look for, and it might be, a Tarloff cyst or something quite puzzling that would have slipped through the system otherwise. So these are all times when we might use imaging, but it was the assessment that informed how to interpret the actual images.
That's very useful, because often as a surgeon, I see patients where a disc has fully slipped, pinched one of these nerves here. This is the side of the spine, and is causing pain in the leg. But for the back pain alone in that patient, in your opinion, is that because you feel the nucleus, the content of that disc on the inside is perhaps a bit mobile, a bit unstable? What do you think is causing that? What is the reason for that pattern?
So let me give you two possibilities for the scenario you just described. So you can look down through the transparent vertebra here, obviously it's bone in real life, and you can look into the disc, which is a gel, as you know. If you stand nice and tall and sit nice and tall and squeeze the spine, you'll see the disc flatten under that compression. But if you keep bending over and over again under heavy load, so say you are lifting with poor form over and over again, this is not a ball and socket joint like a hip or a shoulder. It's actually a adaptable fabric. It's made up of strands of collagen. And just like my shirt is a fabric, if I wanted to delaminate the fibers, I would create stress strain reversals back and forth like this, and I would get a delamination or a separation in the fibers. Well, if my shirt had to hold in a pressurized fluid, the fluid would seep through the delaminations. And this is exactly what happens with discs. So if I just moved a disc back and forth, say I was doing belly dancing as an example, or some activity without much load, we've never measured accumulated delamination of the fibers before. But the combination is a lot of compression load, like picking up something heavy with poor form, and the spine is bent forward over and over and over again. And those collagen fibers delaminate. Now, when I squeeze the spine and bend forward, can you see the delamination opening up there? And I'm driving the gel posteriorly. So to your point and to your example of the 30-year-old, when they sit flexed, for example, slouch down like this, they're squeezing over time that nucleus, which pressurizes and seeps its way through what we call an open fissure. And then when they stand up and walk around, you can see how it gets drawn back in again. And in fact, in some people, if they were to walk over an undulating surface like a golf course, something like that, that actually is more effective in the 30-year-old in vacuuming in that little disc bulge that is pressurizing the nucleus. But there's a rule on that. And that is, if the disc height is 70% of its original height or more, walking is usually very helpful. If the disc is flattened, the chance that walking will vacuum in that imperfection in the annulus starts to reduce quite substantially.
When you say vacuuming, so if that's the spine there, my understanding is if it's bulging a bit and you were to pull this apart a little bit, you create a vacuum inside because obviously air can't get in, and that has a kind of suctioning effect to pull that disc back into its place.
Well, it's actually to be more upright, not to bend forward, as I think you were showing and pulling it apart, but to actually get upright. Now, your low back has a little bit of a hollow in it. So to walk tall and proud sets up the mechanics that equalizes the pressurized gel, and it tends to draw in. But when you bend it a certain way, the disc, on the outside of the bend, the convex side sees more pressure. So you're equilibrating the pressure in that particular case. The polar opposite can happen in someone else. They may have a disc bulge, as I'm creating here with hydraulics of posture and load. And then when they stand upright and walk, as I was showing was the beneficial approach for the previous person, in certain types of discs, if they have more lax type of collagen in their annulus, it will pinch the disc. And now you have a pinched off extrusion. And those are the things that I'm going to be sending people with to see you.
You mentioned, walking on the golf course sometimes can improve that. What other kind of strategies can you do perhaps in your clinic room? What would you get that patient to do?
Well, there's many. Just if sitting at the computer causes their back pain, put a support in their low back and support some of that hollow. Now, if that allows them to sit longer with less symptoms, there is a strategy right there. But the problem with that is sitting longer and encouraging that isn't necessarily the thing to do either. So simply just to get up out of the chair and go for short interval walks might be one. Getting a sit-stand desk, if that's what their job is. So it might be sit for 20 minutes, stand for 20 minutes, and then go for a short walk. And then they'll find all of a sudden they'd prefer to do that than to put up with the back pain. As you know from my book, Back Mechanic, we have 2 chapters on movement strategies. For example, very common to hear a patient say, "Oh, I threw my back out when I sneezed." I'll say, well, have you told your previous clinicians that that was the case? And they said, yes. And I said, well, what did they tell you? And they said, well, nothing. I had to sneeze. But if that's the case and we defined that pain mechanism, we might have them sit on a stool. I said, mimic a sneeze for me, and they'll go, achoo. So they're flexing down, creating an impulsive load, pressurizing the posterior nucleus. And I'll say, well, here's the antidote. And it's kind of hard, but I didn't say it was easy. I did say, if you follow this strategy, lift your chest and sneeze upwards and try and control it. You've taken out the mechanic of creating the offending mechanism of what gave them that acute attack. So the assessment almost always will reveal a mechanism and give away the strategy of a movement hack, a lifestyle hack for that person to utilize and greatly reduce the risk of a future acute episode.
I hope you found that discussion helpful. If you did, please like and subscribe to the channel. It really helps people with back pain and spine disease find information that I try and post on this channel every week. Please visit us at spinemdt.com, where you can try our online spinal assessment tool. Our goal is to find the least invasive solution that gives you the longest lasting result. And as a surgeon, I'm able to do that by working with a whole network of practitioners, so chiropractors, osteopaths, physiotherapists, to meet that goal. Thank you for watching.